हाँ चल ठीक है, वही माइनस पर ऐसे कर। जी मारिया,
Assalamu alaikum. Today the topic of my presentation
आप जरा
is
ऊंचा बोलोगे, आहिस्ता बोलोगे, ऊंचा बोलोगे, ठीक है?
जी sir.
हाँ।
Today the topic of my presentation is abnormal uterine bleeding. Abnormal uterine bleeding is a broad term that describes irregularities in the menstrual cycle, including frequency, regularity, duration, and volume of flow outside the pregnancy. Variations in any of these four parameters constitute abnormal uterine bleeding. It has higher incidence around menarche and menopause. There are several types of abnormal uterine bleeding: heavy menstrual bleeding, intermenstrual bleeding, postcoital bleeding, and postmenopausal bleeding. There are several classification systems for the abnormal uterine bleeding. One that is increasingly recognized is palm coin system. It was developed by International Federation of Gynecology and Obstetrics. Palm coin, polyp, adenomyosis, leiomyoma, malignancy, and hyperplasia, coagulopathy, ovulatory dysfunction, endometrial causes, iatrogenic causes, and others that are not yet classified.
इसमें वापस
जी sir.
The important thing to learn here is that there are these two groups of causes.
Yes sir.
One has been because if you look at the first words and if you make an acronym is when you make a term which consists of the first letters of all the words which are included in that. And if you look at that, it is polyp, adenomyosis, L for leiomyoma, and malignancy and hyperplasia. Now, these four groups of causes, polyps can be of 2 or 3 types. Similarly, malignancy and hyperplasia have been lumped together. Now, these are, if you look and compare with the other group, these are structural causes, structural issues. Polyp, adenomyosis, leiomyoma, malignancy, which have distinct specific anatomic or histological features. On the other hand, these are non-structural causes, like coagulopathy, ovulatory dysfunction, hormonal imbalance, endometrial. It is the response of endometrium to hormones. And iatrogenic are those which are obviously because of erratic or irregular treatment or medication. And then any other cause which does not belong to these 8 groups would be in the 9th, not yet classified group. And these days, this is the classification. There is no other classification which is recognized internationally of abnormal uterine bleeding. So palm coin is that. This is the classification that is used, and this is in use since 2009. चलिए दिया.
The most common cause of abnormal uterine bleeding is heavy menstrual bleeding. It is the most common cause. It is defined as the blood loss of more than 80 ml per period. 20 to 30% of the women of reproductive age suffer from heavy menstrual bleeding each year. In UK, 5% women between the age of 30 and 49 years consult their general practitioner with the heavy menstrual bleeding. Etiology. It includes pelvic pathology within the uterus. Within the uterine cavity, it includes endometrial and cervical polyp, hyperplasia, CA endometrium, and intrauterine contraceptive devices. Within the uterine cavity, it includes fibroid, adenomyosis, sarcoma, and cervical cancer. Outside the uterus includes endometriosis, pelvic inflammatory diseases, ovarian malignancies, and rarely polycystic ovarian diseases.
Is not really such a cause of abnormal uterine bleeding. आप ovarian pathology कह सकते, ovarian dysfunction कह सकते, not ovarian cancer.
Yes.
Ovarian cancer usually occurs late, usually in the menopausal age. Even if it is earlier, it is not the hallmark of ovarian cancer is not abnormal uterine bleeding. तो उसको उस तरह से नहीं इसमें इस्तेमाल करते.
Yes. Clotting defects, medical disorders which include thyroid dysfunction and the drugs, progesterones and warfarin. Management. The main objective of the management of the patient of abnormal uterine bleeding is to find out the cause, and the management includes detailed history, thorough examination, appropriate investigations, and treatment of the cause. Menstrual history, to find out the changes in the amount of the blood loss per day, days of bleeding, and the length of the cycle. Amount of loss can be estimated by the number of pads used, their soakage, and the passage of
नंबर
clots.
इस्तेमाल करो तो नो के बाद फिर फुल स्टॉप होना चाहिए. अदरवाइज ये लगता है कि बाय नो.
जी सर.
नंबर का मतलब है या तो पूरा नंबर लिखो NUMBER, या अगर वही लिखो NUMBER.
जी सर. Comparison with the previous cycle, patient should ask about the pattern of the bleeding before and now, and one must appreciate the increase in days of bleeding and alteration in the length of the cycle. Intermenstrual bleeding and postcoital bleeding are suggestive of the endometrial and cervical lesions, for example, polyp and carcinoma. Uh, Abnormal uterine bleeding is also associated with the pain, which may be in the form of dysmenorrhea or dyspareunia. A detailed information about the type, onset, severity, and its relation to the menstrual cycle is important to reach the exact underlying cause. Dysmenorrhea and menorrhagia start simultaneously in the patient with the adenomyosis, and dysmenorrhea precedes the menorrhagia by variable period of time in endometriosis and pelvic inflammatory diseases. Certain contraceptives like progesterogens and IUCDs are known to cause abnormal uterine bleeding. Other general symptoms of underlying diseases which cause abnormal uterine bleeding includes bleeding disorders, which includes the history of bleeding from other sides, generalized bruising, history of any anticoagulant ingestion. Examination. A general evaluation of the patient should be performed to exclude the signs of anemia, evidence of any systemic coagulopathy, and thyroid diseases. Abdominal examination. Abdominal examination is aimed at detecting any abdominopelvic mass which may be responsible for the presenting complaint. When it presents, its position, size, mobility, surface consistency, and the presence of tenderness should be noted. Any evidence of organomegaly or presence or absence of ascites should be noted. Uh, uh, pelvic examination includes speculum examination and bimanual examination. Every patient with the abnormal uterine bleeding should have uh, a per speculum examination to examine any focal lesion like polyp or any malignancy. IUCD thread can be visualized if there is a history of IUCD insertion. Bimanual examination should also be performed to elicit the uterine enlargement. Uniformly enlarged uterus may be due to adenomyosis and single fibroid, and irregular enlargement can occur due to the presence of the multiple fibroids. Tubo-ovarian masses are usually tender and associated with the restricted uterine mobility. Investigations. Full blood count should be done in all the women with the heavy menstrual bleeding. Coagulation screening, if history is suggestive of any coagulation disorder. Thyroid dysfunction, if the woman has any symptoms of hypo or hyperthyroidism. Endocervical or high vaginal swab if the history is suggestive of the risk of infection. Pelvic ultrasound is the investigation of choice in evaluation of the patient with the abnormal uterine bleeding. Transvaginal ultrasound is superior for all for small submucous fibroids and endometrial polyps. Uh, 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 these cannot be missed as they can be missed on abdominal ultrasound. Coagulation profile and thyroid function tests. Laparoscopy is not
आपने
routine.
coagulation profile काफी दफा आया है. Coagulation profile किस एज ग्रुप में होती है नॉर्मली
सर अगर ब्लीडिंग की हिस्ट्री सिंस मिनार्की है तो उसमें आप सस्पेक्ट कर जी सर जी सर
तो उसमें होता है और उसमें खास तौर पे वो वॉन विली ब्रांड डिजीज होती है जिसको जो वो फैक्टर वॉन विली ब्रांड फैक्टर वो देखना होता है
जी सर.
इन women of say 20s 30s 40s उनमें it is not really a diagnosis which one would generally be considering until and unless there is overwhelming evidence or overwhelming features which suggest that there may be clotting issues. तो वो इसलिए इसको खास तौर पे ये कह देना कि in younger girls soon after menarche और उस पीरियड में जो प्यूबर्टी का पीरियड है उसमें हम इसको उस तरीके से देखते हैं and we try to rule that out.
Laparoscopy is not routinely indicated investigation, but it can be done in the cases where the nature of pelvic mass is difficult to assess on the ultrasound. CT and MRI only indicated when where the pelvic malignancies are suspected.
I don't really think laparoscopy would help anywhere in abnormal uterine bleeding. I can't really think of any cause जो कि आपको pelvic examination और ultrasound पे ना मिले. और कौन सी कॉज ऐसी होगी जो आपको ट्यूबोवेरियन जो पैरामीट्रियम में pelvic inflammatory disease है, you can get good assessment of that. एंडोमेट्रियोसिस अलबत्ता हो सकता है पैची एंडोमेट्रियोसिस, अदरवाइज एंडोमेट्रियोटिक सिस्ट जो है उनकी डायग्नोसिस भी उस तरह से हो जाती है. एडिनोमायोसिस दैट इज सीन बेटर विद अल्ट्रासाउंड देन ऑन लैप्रोस्कोपी. तो लैप्रोस्कोपी इज अ पुअर डायग्नोस्टिक और उसको मेंशन करना हो तो one I'll have to think. I can't really tell you offhand what condition which causes abnormal uterine bleeding will be diagnosed by laparoscopy, which cannot be assessed on pelvic examination coupled with ultrasound. और अगर वैसे भी देखें तो CT is not so important. MRI perhaps to some extent. Otherwise, ultrasound is the investigation of choice. चलिए अगर किसी के जहन में आए कोई ऐसी जो कि लैप्रोस्कोपी पे आप देख के बता सकते हो अपार्ट फ्रॉम पैची एंडोमेट्रियोसिस, वो उसके अलावा और कोई नहीं.
When selecting appropriate management for the patient, it is important to consider patient's condition, risk, and benefits of each option, contraceptive requirement, past medical history, and previous surgical history. Medical treatment includes non-hormonal and hormonal treatment. In non-hormonal treatment, antifibrinolytics such as tranexamic acid reduces the blood flow up to 50% by inhibiting endometrial fibrinolysis. Antifibrinolytics are prescribed for the women, are not usually prescribed with the women with the history of thromboembolism. Prostaglandin synthetase inhibitors such as non-steroidal anti-inflammatory drugs inhibit endometrial anti-inflammatory prostaglandin production, leading to the reduction in the menstrual flow. Mefenamic acid is the most frequently used and it reduces the blood loss by 25%. The drug is taken during menstruation and has the advantage of additional analgesic properties. Hormonal treatment includes combined oral contraceptive pills. It considered to be effective in the management of heavy menstrual bleeding. It reduces bleeding by 50% and has the additional benefit of reducing the dysmenorrhea. Levonorgestrel releasing intrauterine system is also an excellent alternative to the surgery for the women with the heavy menstrual bleeding who seek reliable long-acting reversible contraception. Most women use this for contraception along with the benefits to reduce menstrual bleeding. It may insert it in the outpatient settings and requires changing every 3 to 5 years depending on the preparation inserted. The low dose of levonorgestrel released into the uterine cavity and it leads to the endometrial atrophy. Oral progestrogens. They are also helpful in the management of women with the irregular heavy menstrual bleeding. GnRH analogs act by down regulating the hypothalamic pituitary ovarian axis and it induces the ovarian suppression leading to the amenorrhea.
एनालॉग में यूजी के बाद होता है, पहले नहीं.
Surgical treatment is restricted to the women from whom medical treatment for whom the medical treatment has failed, where there are associated symptoms such as pressure symptoms from fibroid or prolapse. Women who have their family completed. Surgical management includes endometrial ablation, uterine artery embolization, myomectomy, and hysterectomy. Endometrial ablation is the targeted destruction of endometrium and some of the underlying myometrium. It is suitable for the women who have completed their families. All organic and structural causes should be ruled out. Myomectomy can be done by abdominal laparoscopy and hysteroscopic route. It is the surgical removal of the fibroids from the uterine cavity with the conservation of the uterus. If the fibroid protrudes into the cavity, it should be removed hysteroscopically. GnRH analogs are often used for up to 3 months prior to the surgery to reduce the size and vascularity of the fibroids. Immediate complication of the myomectomy usually relates to the excessive blood loss and need for the blood transfusion. Uterine artery embolization. It is a well-established technique for the treatment of fibroids. It is carried out by the interventional radiologist under local anesthesia. Blockage of both uterine arteries results in the fibroid becoming avascular and shrinking. It requires a short hospital stay. Reduction in the fibroid volume of 30 to 46% has been reported. Symptomatic improvement in 85% of the women can occur. Hysterectomy. It can be done by abdominal, laparoscopic, and vaginal route. It should be considered only if the woman has had completed their family failure of the medical treatment. It should be considered in the treatment of heavy menstrual bleeding when woman has completed their family and but in those who want their ovaries to be removed due to family history of ovarian and breast CA, they should be counseled for the need of hormonal replacement therapy until the age of menopause. Complications of hysterectomy includes damage to the bladder and ureter, damage to the bowel, major hemorrhage, infection, pelvic abscess, thromboembolism, and long-term complications include prolapse and urinary incontinence.
तुमने तो टॉपिक दिया था AUB because of fibroids. सना मैंने नहीं दिया, तुमने ही लिखा था. वो ज़ारा ने लिखा था, मैंने मैसेज किसने किया था? मैंने फॉरवर्ड किया था. हाँ फॉरवर्ड किया था, तुम्हारी तरफ से आया कि abnormal uterine bleeding because of presentation by Dr. Maria Ahmed on AUB due to fibroids. ये ज़ारा सबरीन का भी यही मैसेज है. फिर तुम दोबारा संडे को ज़ारा ने किया था और आज मैंने फॉरवर्ड किया. चलो ठीक है. मैं तो क्योंकि उसके बारे में बात करने के लिए आया. हम नेट पे तो नहीं है ना? हैं? उस पे आते हैं कमेंट्स ऑन कर दो. हाँ करना बिकॉज मैंने वो मेरे पास था मटेरियल काफी सारा था बट मैंने वो उसमें 2-3 चीजें जो है मैं दिखाना चाह रहा था. तो उस पे कनेक्ट कर दे हैं. हाँ क्योंकि आधा घंटा है, आई कैन गो थ्रू दैट. हाँ वो तो मैं कर लूंगा. यहाँ पे नेट कौन सा चल रहा है? हेल्थ केयर है या एग्जीक्यूटिव का? एग्जीक्यूटिव. ये मैं है कि हाँ
मिनिमाइज होगा ना.
ये तो है.
तो उसमें फिर इशू आ रहा होगा, आपको दूसरा कनेक्ट करना होगा. तो सर मैं देखता हूँ कौन सा चल रहा है.
हाँ मुझे
ठीक है.
यहाँ पे जो प्रेजेंट हो रहा है वो ट्रांसमिट भी हो रहा है.
जी वो तो ट्रांसफर शेयर्ड हुआ है सर. सर मोबाइल पे आपका कौन सा कनेक्टेड है?
मेरा कोई भी नहीं कनेक्ट, दोनों कनेक्ट नहीं हो रहे हैं ना. वो हेल्थ केयर है और एग्जीक्यूटिव है मेरे पास. HLH है, HLH यूजर भी है.
सर का एग्जीक्यूटिव वाला
इधर इलाज सर फरूख का कनेक्ट करोगे. क्या है सर?
एलर्जी स्मॉल टॉक एलर्जी.
ठीक.
कौन सा है?
सर हेल्थ केयर सर कनेक्ट करेंगे. जी सर. हॉस्पिटल मेडिकल. जी सर. मोबाइल पे कनेक्ट कर दूं सर आपको?
ये अच्छा होगा. ये भी घूम रहा है. आ जाओ तुम, आ जाओ. ये इसमें
इस सिस्टम से आप स्टॉप शेयरिंग कर दो.
राम तुम तो IT के बंदे बन गए हो.
चलिए आपका कनेक्ट हो गया. मैं इधर से
ये मैं इसके साथ वो शेयरिंग कर सकता हूँ इधर बैठ के. अगर मैं कर दूंगा
मैं देख लेता हूँ सर.
जी सर बिल्कुल कर सकते हैं. ये स्टॉप शेयरिंग हो जाए यहाँ से PDF वाली तो हो जाएगा.
वो मैं वो RLMC पे ही जाऊंगा ना.
जी सर RLMC वाले पे.
RLMC गूगल मीट.
यस सर. सर यहाँ से बंद कर दूँ इसको. ये वाली मीटिंग चल रही
हो
है.
जाएंगे.
हाँ सर उधर से कनेक्ट करेंगे ना अपने लैपटॉप से
अच्छा
कनेक्ट.
अच्छा चलो.
सर आपके इसी स्क्रीन से जब शेयर करेंगे तो प्रोजेक्टर पे आ जाएगा.
जी सर, ये आप इधर से
Okay. वो
सर पोडियम वाले लैपटॉप से ना म्यूट कर दें।
हेलो,
सर आप बस प्रेजेंटेशन पे नीचे क्लिक करेंगे तो वो डिस्प्ले पे आ जाएगा।
First of all, actually, there has been a little bit of confusion, and I was given to understand that today's topic would be abnormal uterine bleeding due to fibroids. And that's why I have a bit of material which I thought if I share with you would be of use. Number one is it is important that in that palm coin classification, this is a sub classification of the same. And these days, the site of the fibroid, a good ultrasonologist will say that there is one large fibroid, number one. That would mean that it is a submucous fibroid. If you look at that, this is a diagram which I would want all the residents and all concerned to memorize. Zero, it starts with zero. Zero is which is completely in submucous pedunculated, lying in the uterine cavity with a stalk attached to the uterine wall. And if you look, and then as it gets outside, the number increases. Number one is which is more, which is projecting into the endometrial cavity, but is within the uterine wall. So some mucous fibroid, which is less than 50% intramural. And if you look at number three on the other side, that is touching the endometrial cavity. Number three, contact with endometrium, but 100% intramural. And number two, where is number two is which is less than 50% or more than 50% is in the intramural, and so on it goes. 4 is completely intramural. It is neither closer to the serosal surface nor to the endometrial surface. Number 5 is which is more than 50% within the surface. And number 6 is which is less than 50% in the uterine wall and more towards the surface. And number 7 is which is pedunculated subserous fibroid, which is outside the uterus. And when there is this large fibroid, it is your mic is off. Is it? मैंने अपना माइक ऑन करना है।
सर आवाज आ रही है आपकी।
हैं?
सर आवाज आ रही है आपकी।
चलो किधर गया? So this is how, because it is more descriptive. If you say it's submucous fibroid, there are if you look at this and you find that there are 3 varieties of submucous fibroids: 0, 1, 2. And if we denote that by 0, 1, or 2, that becomes more clear to someone who is assessing or who is looking at the findings. Because 0 is, and to some extent, number 1 is amenable to hysteroscopic removal. whereas number 3 won't be, although number 3 is in contact with endometrium. And so therefore, this type of classification that also tells you as to how to approach that. Now, this was about the physico-anatomical classification of uterine fibroids. And then I'm going to share with you another presentation, which is about uterine fibroids treatment. This is a presentation which I got from the net. I need to change my computer. So this again is that shows the FIGO classification of the just a minute. Right. So we know that these are benign tumors, and the symptoms are mostly by submucous fibroids and other fibroids when they become larger, weight, etc. So far as bleeding symptoms are concerned, they are related mostly with submucous. Other fibroids can also cause that. The mechanism by which there is abnormal bleeding from the uterus because of fibroids, one is that they increase these submucous fibroids, increase the surface area, and they may have rather delicate and fragile surface covering, and that bleeds. The polyps, fibroid polyps, they would lead to abnormal or irregular uterine bleeding also. But other fibroids like intramural or large subserous fibroids, they can also cause heavy menstrual bleeding because of the congestion, because of increased blood supply to the uterus. And that's the mechanism for those, not directly as such.
Let's make hybrid fibroid hybrid care.
Hybrid is which is 2,5 hybrid, because they have not given here numbers, but if you can, for example, subserosal is 0, the lower one, the upper one is number 1, and on the other side that is number 2, right? And then this intramural is number 4, lower one, and the upper one is number 5. And then subserous, if you look at that, the lower one is number 6, and the both of them, they are number 6, and that above one is the 7. And then there is a cervical fibroid. This hybrid is which is impinging upon the serosal surface as well as the submucous surface. Heavy menstrual bleeding, fibroids can lead to that. And anemia, which is a consequence of heavy menstrual bleeding, and because of anemia there is fatigue, weakness. This is how the patient feels, bloating and pelvic pressure symptoms because of, and the pain because of the weight of the fibroids, and then affecting the fertility, miscarriage, preterm labor. If you start chronologically, number 1, fibroids may cause infertility, so no pregnancy. If pregnancy occurs, there can be miscarriage. That is the early pregnancy. Later pregnancy, there is preterm labor. When the labor occurs, it can result in postpartum hemorrhage. Yes, I am talking. ये किसी को आवाज नहीं आ रही, बाकी तो कह रहे हैं कि आ रही है. ये इमरान देखें तो. So
आवाज आ रही है.
Okay, ji. So the emphasis here, actually, if you look at various international movements like Black Lives Matter, like Me Too movement, like acceptance of transgenders and gay people, LGBT, etc. And now people have become very sensitive about the kind of words that we use, the kind of terms that we use, and we have to be careful about that. Similarly, we need to, in our part of the world, we need to catch up with some of the other areas also. For example, it is just not enough to only treat the patient or give her some medicine or prescription. We need to get engaged in conversation with the patient, knowing how she feels about it. And if you look at in the yellow bar, there is uterine fibroids have a significant impact on quality of life and are the leading indication for hysterectomy. ये यूनाइटेड स्टेट्स की बात होगी, बाकी को छोड़ दो, लेकिन impact on quality of life is something which is being emphasized here. So that is something, that is the conversation that we need to have with the patient. And we will tailor our management according to the requirement of the patient. In the later part of this, if we reach that part within this time, you would appreciate that there is a history presented of a woman in this or in a similar other presentation. In that, the woman has completed her family. She is plus 40. And she has been advised hysterectomy. She says, I don't want to have hysterectomy. I don't want to part with my uterus because it's an important part of my body and it gives me the sense of being a female, a woman. Now, because of that, to us, most of us, under the present frame of mind, we would think that this lady is rather out of her mind, that she is trying to maintain or keep a useless organ, which is going to be of no use to her, no reproductive function. And then removing the fibroids may still not alleviate the bleeding, or the bleeding, abnormal bleeding, may come back in another form. So the best treatment is hysterectomy. But even if, medically speaking, if our experience tells us that is the better approach, but if the woman doesn't want to do that, so you can't remove that. So that is the kind of understanding, that is the kind of sensitivity that we need to show to our patients' feelings and their viewpoint about it. And also, unfortunately, in our OPDs, we do not have time to make the patients understand or listen to them, listen to their complaints about it. Now, if you look at a patient who has traveled, say, 30 miles or 40 miles, come from another city, or even from within the city, she has taken the whole day in coming to the hospital, waiting in the OPD for 2 or 3 hours till her turn comes. And if we just brush her off and summarily dismiss her in 5 minutes, giving her a prescription, that prescription or treatment may be 100% absolutely correct and and would be defendable in examination or to scrutiny. But so far as that patient's many unanswered questions are concerned, she would go back unsatisfied. And we as doctors need to inculcate within us that faculty in which we understand the patient's difficulty, the patient's feelings about it, and then we treat her. And that applies not only to fibroids, but there are more sensitive matters, like infertility. When we discuss that, we need to address that. And, you know, when we talk about this, certainly some examples come to mind. A day before yesterday, I had a patient in my clinic who was complaining of lower abdominal pain. She had had cesarean section. She had a laparotomy for ectopic pregnancy, about 5 laparotomies in all, including those 3 cesarean sections. And she was complaining of pain. On examination, there wasn't anything. On ultrasound, everything was okay. But she had pain. And she came from the next step would have been a diagnostic laparoscopy, and if needed, laparoscopic surgery. That is, in my opinion, would have been the approach to find out what is the cause of her pelvic pain. But I still think that I did not spend enough time with her to make her understand that. And it still pinches me. I mean, it's been 48 hours, but I still am smarting with that feeling that I did not do justice to her and tell her about it. So it is important that we, and similarly, a colleague of mine brought her daughter, and she had premature ovarian failure at the age of 27. So I was kind of cold medical terminology. I explained to them that this is what has happened. This is, this is unfortunate, but that's it. But now that is the kind of patient with whom perhaps I would have spent, or I should have spent, about half an hour listening to her, because the information that I gave to her uh, would have taken a lot of time in sinking in making its impact. Right? Immediately you blurt out to someone that you have cancer. That's a devastating news. That's a devastating statement. And so we need to take into consideration the patient's feeling and break the news, or tell them about the diagnosis in a proper manner. And that is actually, this is the kind of message that I would want to convey more importantly than talking of fibroids, because this is something that you can always find in the books. But we seldom get that kind of detailed emphasis on these aspects of our patient management, as I've just said. And even if we come across that kind of paragraph, we skip it. We just go on to the important clinical aspect of it. Now, heavy menstrual bleeding, she also said, is the most common symptom of uterine fibroids. And more than 70% of women with fibroids, they complain of heavy menstrual bleeding. These are various areas which need to be explored and addressed. We don't know very much about these. Now, they are talking of microbiomes and what's got to do with uterine fibroids, exosomes. We know that estrogens favor development of fibroids, infertility favors development of fibroids, and there are, and then in darker color women, the blacks have the maximum incidence, browns have lesser than that, and the whites have even lesser than that. So what are these factors which cause that? And I would challenge you all to look at various. How many of you know exosomes? I didn't know when I looked at this slide. I didn't know what exosome is. So I looked up. Exosome is a small body, which is a cellular body, which is attached with the cell membrane, outside the cell membrane. And epitranscriptomics and fertility-friendly therapy, or etc. But now prevention of uterine fibroid. How do you do that? हेलो, मैं क्लास में हूँ, मैं आ रहा हूँ बस थोड़ी देर में. हाँ, बस 5 मिनट में कर लेना, ठीक है. So these are important questions, and as postgraduates, I think that you should start looking at them. As many a times I have said that it is not the purpose of exploring various subjects is not only to pass the examination and not only to become good specialists, but also if you look at some of these questions, they might stimulate your curiosity in the direction that you would start looking at some research or start doing it. And this is how actually you explore things and you discover things then. So management of fibroids, this is a summary of the management, that how do we go about it. जी ये खिजर भी उन्होंने हाथ रेज किया है. हाँ?
नहीं, वो करेंगे.
वो करेंगे.
आप ओपन क्यों कर दें?
हाँ, ओपन क्यों कर दें तो. Now the management of this is the treatment, medical, interventional or surgery. और इसमें आप देखो मेडिकल जो है वो है, सर्जरी में मायोमेक्टमी, हिस्टेरेक्टमी है, और दरमियान में इंटरवेंशनल है. दैट इंटरवेंशनल इज यूट्राइन आर्टरी एम्बोलाइजेशन, वो है. या अब जैसे हाई फ्रीक्वेंसी अल्ट्रासाउंड आ गया, high frequency ultrasound also is a method of doing that. Those are interventional. Medical is when management of symptoms, and then there is targeted therapy. I'll rush through some of these slides because there is an important part of medical treatment which I would want to tell you about, and I wouldn't say introduce, but tell you something which is now getting recognized in 2020 and 2021. Long-standing options for treating uterine fibroids, limited efficacy or tolerability issues. ये ऊपर वाला जो है ये शायद ना पढ़ा जा रहा हो, not indicated specifically for uterine fibroids for symptom management. मारिया ने अभी कहा जैसे कि levonorgestrel system है, ये combined oral contraceptive pill है. Abnormal bleeding के लिए these are combined oral contraceptive pill is a useful, and similarly oral progesterone, they are the first line of treatment till you make a definitive diagnosis, and they are all right, but necessarily not in fibroids, because fibroids have not a hormonal but more of a mechanical issue which results in that bleeding. And similarly, levonorgestrel IUD would not address abnormal uterine bleeding due to fibroids because of lack of contact, because of that larger denuded surface of the fibroid projecting into the myometrial, into the uterine cavity, which is causing that. So it may not be that effective. So, and tranexamic acid is a very good treatment, but that can be given only for a few days. You cannot give it for a prolonged period of time. And please mind you, these days we come across patients who have been taking tranexamic acid for say 20 days. This is not the right kind of approach. It is a treatment, or it is a medicine which should be given only for 2, 3, or 4 days maximum. That's all. And if the bleeding still persists, then you should switch over to something else. Then something else needs to be done. And then GnRH agonists. Agonists or analogs are the same, and they are in use for now a couple of decades, even in fibroids, to reduce their size, etc., and vascularity for operation. But the downside is that as soon as their effect, and you can give them only for about 6 months, and when their effect wears off, the size and vascularity, they come back. Now antagonists have come in. You see, when analogs were introduced in 80s, we used them, analogs for IVF, and at that time they came in, initially they came in nasal spray analogs, nephrolene or something, I forget the name of that inhalation agent. And then came in the injections of like leuprolide or others, like Zoladex. They were injectables. And then there was a daily injection, then there came a 4-weekly injection, and then there was also, that was about 10, 15 years ago, when that 3-monthly injections came in of 11.5 milligram, which would be effective for 3 months. So those were analogs. Analogs have a disadvantage of causing a flare-up. Initially, they increase the level of FSH and LH and also of estrogens, and increase the symptoms. Antagonists are the drugs which block the receptors at the pituitary, and they stop production immediately. They stop production of FSH, and thereby the effect is quick, and there is no flare-up. And now the important thing is that antagonists have come in an oral variety. That is the biggest advantage that they have. So this is the mechanism by which they block. GnRH receptors are blocked by GnRH antagonists, reduce the LH and FSH, and therefore the ovaries and the estrogens. Ye band ho gaya. These are the 3 preparations. Legolix was the first one which was introduced, and that was a few years ago, about 6 years ago. And it is given in a dose of 300 or 150 milligram. And we'll talk about that. And this is the middle one. Relogolix is the new preparation, and it has come in a combined therapy also with estrogen and also. And Linzagolix is the latest one, which is still under trial. So there have been quite a few of these trials. Elagolix is given, it's approved in the United States in 2020, and management for heavy menstrual bleeding, which is associated with uterine fibroids, and in premenopausal, obviously, for heavy menstrual bleeding. And the dose is 1 capsule in the morning of 300 milligram, which also contains estradiol 1 milligram and norethistyrone acetate. In America, they called it norethindrone acetate. Over here, we call it norethistyrone acetate, Primula-10. But Primula-10 comes in dose of 5 milligram tablet. That is the preparation that is available in Pakistan. But in this, the dose or the amount of norethistone is 0.5 milligram, and one capsule in the evening which is only Elagolix and doesn't has progesterone. बस ये मैं ख़त्म कर लूँ. बस ये मैं दो ये स्लाइड मुकम्मल कर लूँ. इसके साथ रिलोगलिक्स है. इसमें ये D2 गलत लिखा हुआ है. E2 का इसका मतलब है दिस इज 40 मिलीग्राम रिलोगलिक्स once daily with estradiol 1 milligram and norethistone 0.5 milligram. It has already been, this is 2021 thing, and this is already approved in Japan for management of symptoms. And this is Linzagolix. This is still undergoing trials. अब ये इनके methods of evaluation है, इनकी studies हैं, उनके मुख्तलिफ वो है. We need not go into that. Fibroids की volume को कम करते हैं. And this can be given for 6 months, and you need not worry about bone mineral density effects of these because they have estrogen, some dosage of estrogen and progesterone as well. ये combined therapy इसीलिए कहा गया Relogolix CT QD का मतलब है, and it can be given for 24 weeks. 24 weeks is 6 months वाली बात बनती है, लेकिन इसमें वो वाले effect नहीं है जो उस तरह से आते हैं. And this is the kind of effect that ये various studies हैं जो उन्होंने placebo के साथ की हुई हैं. ये है conclusion के 3 new and emerging options for treatment of fibroids. Elagolix approved, Relogolix approved, and Linzagolix जो है that's in development. Goal of therapy is eliminate symptoms while preserving the uterus whenever possible. और इसमें start patients on medical treatment first, and then if that fails can go on to more invasive therapy systems. वो उस तरह से होता है. So ये है, ये प्रेजेंटेशन में ज़रूर शेयर कर लूँगा जी. ये फरहत नवाज उन्होंने पूछा है. ठीक है जी. चलो 9:30 हो गए हैं. इसी की एक और है प्रेजेंटेशन. अगली दफ़ा मैं 15-20 मिनट में वो भी बता दूँगा. ओके, थैंक यू.